want to welcome everybody back. And I'm going to go ahead and introduce our next speaker. And it is my distinct pleasure to introduce Dr. Kate Guastaferro. Like I said earlier, she is one of my most mentors. Dr. Guastaferro is an assistant research professor in the Center for Healthy Children and an affiliate of the Child Maltreatment Solution Network and Edna Bennett Pierce Prevention Research Center at the Pennsylvania State University. Her program of research sits at the intersection of prevention science and innovative methods. Her focus during her time at Penn State has predominantly been on the prevention of child sexual abuse. Dr. Guastaferro is also interested in innovative methods for intervention development, optimization, and evaluation. An expert in the multi-phase optimization strategy, she has experience applying most to a variety of public health problems, including STI prevention among first-year college students. Dr. Guastaferro is actively building a program of research that integrates her interests to develop, optimize, evaluate, and disseminate child maltreatment prevention programs that are effective, efficient, economical, and scalable. And so with that, now, Dr. Guastaferro, the floor is yours.
I should have unmuted before I shared my screen. Can you see it? All right. Okay, thank you. And thank you, Dr. Wells, for a very wonderful introduction. And thank you all for being here and being interested in learning more about MOST. My opportunity and purpose of being here today is to showcase how MOST could be applied in a different field of study. And so we'll focus predominantly on the prevention of child maltreatment. So Dr. Wells gave a great presentation. I'm imagining all of you sitting at your desks, being so excited, ready to take on MOST in your area of study. Great. But as you start to think about it and you're getting into the practical details, perhaps you're feeling a little intimidated, confused, overwhelmed. I get it. You might be thinking about, how can this actually work in your setting? How will you actually be able to pull this off? For me, it was, how do I suggest this extremely radical new way of thinking to a very established field of study? And importantly, Dr. Wells did touch on this, but can you actually get funded to do it? And my philosophy, I take inspiration from Tim Gunn here, is you make it work. You can do it. You just have to be a little creative sometimes. So the overview and kind of plan of what I'm going to talk about today, I'm going to make a case for why the field of child maltreatment needs MOST. That's kind of, the justification, the background, what I'm going to try and address. Then we'll do a didactic, practical application of MOST in an intervention designed to prevent child maltreatment. And then we'll end with some lofty thoughts about alternatives and considerations that you might want to just know about. And then I'm hoping to have lots of time for questions and discussion. All right, so child maltreatment, tough topic. Here is why it is important. In the last available data, so for fiscal year 2020, there were 618,000 children under the age of 18 who were determined to be victims of child maltreatment via report to Child Protective Service systems. And when I say child maltreatment, I mean physical abuse, neglect, emotional abuse, and sexual abuse. Preventing child maltreatment has been around for decades, and the prevailing strategy are home visiting programs, where an individual educator comes into the home of a parent, works specifically with the parent to improve risk factors. So home visiting programs, the prevailing strategy, and indeed almost $2 billion of federal funds have been allocated for home visiting programs. For example, the Maternal Infant Early Childhood Home Visiting, or MICV program, that is funded with federal dollars. They served more than 140,000 parents and children during fiscal year 2020 in over 925,000 home visits. So this is a big enterprise, right? And these home visiting programs are designed to foster parent knowledge and skills, basic parenting behaviors, provide social support, develop coping and problem-solving strategies, and then also designed to increase community referrals. So that might be to mental health or substance use treatment. Now, the thing about these home visiting programs, there's a lot of money behind them, but there is varied effectiveness when we look at these programs. And so I'm citing here a meta-analysis of, I forget the number, quite a number of home visiting programs. And the overall effect in reducing child maltreatment, they found a Cohen's d of 0.29. So that's moderate, small. That sounds, okay. But we could do better, right? When we look specifically at the studies of home visiting programs among samples that come from the Child Protective Service system, so high risk, we already suspect or know that something is going on, that effectiveness ranges now from 0.018 to 0.53. That is a massive range, right? So we've got a lot of things that kind of work and some things that really might not be working. We have more to do. So I suggest that the prevention of child maltreatment is falling short in this regard. We have varied effectiveness of these programs. We need to do better. And in that same breath, we need to recognize that these programs do not show a demonstrated effect on rates of child sexual abuse. So we don't know that these programs that have $2 billion allocated to them do anything to prevent child sexual abuse. It's a problem. The second problem where child maltreatment is falling short has to do with engagement. So 60% of parents who are referred to home visiting programs decide to enroll. Of those 60%, less than 80% receive the number of intended visits. And further, only about half of whom enroll half of whom who enroll are dropping out before the program is finished. So they're not getting the intended dose, if you will, right? So what happens next? People are dropping out. That means we've got to try and get the program to them as fast as possible. That's an implementation constraint. And so providers in the field are making ad hoc modifications to a program, thereby taking away from the evidence behind that program, right? So we need to figure out what we can do to do better. And the host of home visiting programs that are out there have been developed using that classical treatment package approach that Dr. Wells presented to you. So I'm going to use a different variation of this graphic, but the idea is the same. We identify components that we think are really important to affecting the outcome of interest. You do this through theory, you do this through empirical literature, you can take into account clinical practice, all of those things. And we decide that in order to prevent child maltreatment, we need to improve parent-child interaction. They need to know about child development. We need social support, community referrals, problem solving, things I told you about. We take all of those things, package it up into that black box of an intervention, and then we test it in an RCT. And as Dr. Wells submitted to you and demonstrated, we have some questions that are not able to be answered when we do it that way. And I will just use that to segue into my call and my belief that we need an innovative, novel approach to intervention development and evaluation in the field of child maltreatment prevention. Enter MOST. And I think, you can see here that same graphic that Dr. Wells kind of walked you through. We're going to do MOST with child maltreatment. We're going to still identify those components through empirical literature, theory, We know that we think that we really need to include these, but before we package them together, we're going to subject them to empirically based optimization. The results from that optimization trial will help us identify the optimized intervention. That box becomes translucent. We know what's happening between these components and our outcome. And then we test that optimized intervention with an RCT, right? So just wanted to reorient us kind of in my space with what Dr. Wells presented to you. Now, let's talk about how we might apply most to child maltreatment prevention using a, please hear this, I'm screaming it at you, a hypothetical applied example of a home visiting program. And this is inspired and taken from a paper that we wrote, Jillian Strayhorn and Dr. Linda Collins, to share with the field of child maltreatment what most could really do for the field. So again, here's this graphic, and you're right, we're going to see it a bunch of times. The 3 phases of most, and we're going to walk through these phases and activities in this content area. So the first thing that we do is develop a conceptual model. This is the template of a conceptual model that I use and that I share with colleagues. It can be as complicated as it needs to be, but this is the starting point. And the elements are the intervention components, you're identifying mediators or the causal factors, and then your outcome of interest. And I will tell you that when I read a conceptual model, I go from left to right. Remember that the purpose of the conceptual model is to depict what you're trying to change. When I first heard Dr. Collins talk about this being the engine of your intervention, it really clicked for me, and it helped me kind of orient my thinking about what I'm trying to convey in a conceptual model. So the part in the circle, this is what you are suggesting is going to cause the outcome. And that is important to point out and recall that that's where theory comes in. All right, so here is my hypothetical example of the conceptual model. I'm showing you the end product, and then we're going to build it back up. So we're going to, when we read a conceptual model, we go from left to right. But when we build a conceptual model, I go from right to left. So we start with the outcome. What are we designing an intervention to do? And in this space, we are designing an intervention to reduce the potential for child maltreatment. And I have a specific measure, a continuous outcome that I am able to use to assess that outcome and change in that outcome. Using theory, using literature, I decide that in order to reduce the potential for child maltreatment, I need to first improve parenting behaviors and skills. Makes sense? But I also think that I need to improve parental engagement. So you saw from my justification starting point, these are the 2 things that I think we need in order to affect the outcome. Now the decision becomes, what are the ways to affect that outcome? What are the mediators? How am I going to affect change in parenting behaviors and skills? So I decide that we got to give parents knowledge and skills, right? If I want to improve them, I better give them to them. So the first thing I decide to include here are parenting knowledge and skills. And I believe that every parent needs this information in order to make sense of the rest of it, but also, like, ethically, parents who need parent training should get it. So I'm going to decide that this is a constant component. And I'll just pause to say that a constant component means you are not subjecting it to experimental consideration. So I'm not going to be able to look at it in the way that you saw Dr. Wells lay out the factorial experiment. I'll show you this in a bit. But I believe that every parent needs this kind of information. And so I'm going to include it. Everybody gets it. Okay. That's a constant component. Now, I decide that what I submitted to you at the beginning, none of the existing parent program, parent training, parent home visiting programs have any content related to sexual abuse prevention. And so I want to change that. I would like to enhance these programs by including sexual abuse related awareness and protective behaviors. So I've now added a component about sexual abuse prevention, which will improve parenting behaviors and skills. I also decide that it's important that parents have social support. And so I decide to include a peer mentoring component. Perhaps a recent graduate of the program could call an enrolled person regularly to just see how it's going, to talk about how hard it is to be a parent. So that kind of social support. And I think that when we include social support, we will see an improvement in parenting behavior and skills. Okay. I also know that we have to address stress and coping, because that's going to change the way that you parent really quickly, right? So I'm going to build in a component about problem solving. And I think that these elements are going to all together work towards improving parenting behaviors and skills. Great. Haven't addressed parental engagement yet. So the last component that I decide to add, oh no. I add another component here. Hold on, here it is. They're check-ins. And so this is a way to provide concrete support to parents. So we know parents are dropping out and they don't want to they're not fulfilling all of the requirements of the program. Why? Maybe they have loss of job, childcare problems. Those are concrete elements that maybe we can enhance some support behind. So I decide that the last component to add is something called check-ins. And in between visits, I'm going to call the mother or the father and just see how things are going. So now that I've built my conceptual model, I am able to identify those components. So the components are on the left. You see 5, but recall that the parenting knowledge and skills is a constant component. Okay. We've now made it to the third activity of the preparation phase, which is pilot work. So I saw some questions during Dr. Wall's chat about the pilot study, and please welcome to my TED Talk about the pilot study in the preparation phase of MOST. As Dr. Wells mentioned, the purpose of the pilot study is to generate hypotheses, right? We are not testing hypotheses. You're not powered to estimate effects. The goal and the purpose is to ascertain the acceptability and the feasibility of your intervention. And so that might mean doing a pilot study for each one of your components. Perhaps you can leverage other trials or other data so you don't have to do a pilot study for every single component. But remember, in my example, I'm developing something completely new. So I should probably do a pilot study on sexual abuse prevention before I put it into this big, powerful, magical, if you will, factorial experiment, right? So a pilot study to determine the acceptability and feasibility doesn't have a required experimental design. Anything could really work. You could leverage existing work, you could do qualitative data, you could do a pre-post test, all designed to ascertain the acceptability and feasibility of the component. I'm going to digress for just one second because Dr. Wells did mention the importance of a pilot optimization trial. And so the same logic holds here. You are not powered to estimate the effects of a pilot optimization trial. The purpose is to demonstrate the acceptability and the feasibility of pulling off the optimization trial in a setting or as an early career investigator. And so that is just as important, and we shouldn't look away from that, but I want to be really clear that pilot studies are for acceptability and feasibility. The end of my TED Talk. Thank you. So, recall, coming back, I have to look at the acceptability and feasibility of the sexual abuse prevention component in the sample, in the people that I'm trying to work with. So I leverage an existing trial, and I have data that shows, okay, yeah, this added component will increase knowledge. But a pilot study doesn't have to be powered to detect this effect. What I'm not showing, and what also happened here, was an acceptability and feasibility study and qualitative interviews. I did all of that legwork to be sure that this was gonna work before I put it into my optimization trial. Okay, I'm gonna get off this point now. But I'd love to chat more about pilot studies if we want. The last objective in the preparation phase is to identify the optimization objective. And for those of you who may be familiar with most, this previously was referred to as the optimization criteria. We're just finessing our language a little bit, because if there's anything that Linda Collins has taught me is the importance of language. And so you might hear criterion, but we are switching to optimization objective. So the optimization objective expresses your definition of intervention ease. Remember, the way that we are talking about this is the way that you are going to strategically balance effectiveness with those other qualities we're interested in: affordability, scalability, and efficiency. And what is exciting to me is that every optimization objective can be different. And even if Rachel and I are going to create the same intervention, my setting might have a very, very different optimization objective than hers, which sounds scary as you're learning it, but is so cool. So we'll come back to that. The optimization objective takes into consideration the limitations when it comes to money to deliver the intervention, perhaps staff time to deliver it. I also pay attention to participant time to complete the intervention, but really these are any kind of limitations on resources that make sense within your given setting. And it's your optimization objective. You get to create it. So some examples. Let's say that you want to select the components that will provide the most effective intervention that can be implemented for less than $300 per person. Here, what we are after and seeking is an affordable intervention. I want it to be effective, but I also need it to work within this particular cost parameter. And there's many different ways that we could define affordables, but just this is the example. A different one might be that you want to select the components that provide the most effective intervention completed in less than 1 hour of staff time. You need this to be done within a specific visit at the hospital or something like that. So here you're prioritizing and seeking an intervention that is scalable, perhaps in this respect. It can be easily done and rolled out. For our applied example here, the home visiting program to prevent child maltreatment, our optimization objective is going to be an intervention made up of all active components. What does this mean? We are after an efficient intervention, and cost is not an explicit consideration. I only want to include things that have an impact on the outcome. This might seem easy, but this is, in my opinion, a significant advance in intervention science by trimming things that aren't working. Okay. I'll just mention that though cost might not be an explicit consideration I'm interested in right now, you better believe I'm going to be collecting some data about time to deliver, time to train people to do those components. All of those things will come back into play in my continual optimization of this intervention. All right, so we have conducted the optimization trial, and now, no, what's happening? Here we are. We are conducting the optimization trial. Sorry, we have identified the objective. Now we move into the optimization phase. And the first thing we do is to conduct the optimization trial, which is fully powered or adequately powered and randomized. So this is the big study. This is it. You are powered to detect effects. You are hypothesis testing. All right. This graphic that Dr. Wells also referenced is my go-to, and I really enjoy it because the purpose and the helpful thing that happens here is the matching of your intervention type to your type of experimental design, right? So we know that the intervention I have laid out for you is a fixed intervention. Everybody is getting the same level of intervention. And so the best matched experimental design for that type of intervention is the factorial or fractional factorial experiment. And I'm going to focus on the full factorial. There are lots of elements about the fractional factorial that are really cool and important to think about, but for purposes of just like immersing us in this framework and this design for the first time, I'm keeping it simple with the full factorial. Here is the experimental conditions table for our hypothetical optimization trial. We're using a factorial experiment. Recall that we have 4 components that we are experimentally manipulating. So we have a 2 to the 4th factorial experiment. This yields 16 experimental conditions. And I have powered this hypothetical example to detect a Cohen's d of 0.3. And to do that, or to be able to detect that, I need 352 subjects. I then spread all of those subjects across the experimental conditions. And as you see on the right, I need 22 people per condition. So a person randomized to experimental condition 5, they're all going to get the parenting knowledge and skills, right? So that's why that whole column says yes. But then every other column says either yes or no, representing they're getting the component or they're not getting the component. So a person in experimental condition 5, they get the parenting knowledge and skills, they get CSA prevention, and they get problem solving and check-ins. They're not getting peer mentoring. In contrast, a participant in randomized to experimental condition 12 is getting the parenting knowledge and skills that everybody gets, and then peer mentoring. That's it. So all of the 16 different experimental conditions reflects all of the possible combinations of those components, but we call them factors in the experimental part of this, as well as the levels of those factors. So now we're going to flash forward, and we've run our optimization trial. Yay, here are our simulated results. And these are, again, simulated, hypothetical, but analyzed using factorial ANOVA. So we decide, the purpose now that what we're doing is to identify the optimized intervention, right? So we decide that in order for a component to be included in the optimized intervention, there has to be a main effect with a value of p less than 0.05. So the only components that meet this criterion is child sexual abuse prevention and peer mentoring. So the problem solving and the check-in components do not meet the main effect definition here. We decide that, so after you do the main effects, then you're going to look at the interactions. And we decide that to be included, an interaction must also have a p-value less than 0.05. The only interaction that meets this criteria is peer by problem solving. So this gets interesting, right? Because we have a main effect for peer, but we do not have a main effect for problem solving. So what do? I'm not going to show this to you, but you graph it and you check to make sure that this interaction is synergistic, meaning that it is producing a better than expected outcome. You don't want an antagonistic interaction. And so you have the problem solving component in a significant interaction, but you have to decide, is it worth the cost of including? And there's no written rule about what that means. It has to make sense in your context and your science. So we're going to move now into identifying this optimized intervention. I decide that it's worth it. And so my optimized intervention is comprised of the parent knowledge and skills component, the sexual abuse prevention component, peer mentoring, and problem solving. I've eliminated the check-in. Okay. So what have we done to improve intervention ease? Well, we eliminated a component empirically, and this over time is going to improve the affordability, scalability, and efficiency of the intervention. This is where I get real excited, so heads up. What the factorial experimental design allows us to do is estimate the effect of each component individually as well as in combination. And so in my field, we recycle the same components across any number of interventions. And Rachel's nodding, I know that this happens in your field. We know that we think that these things work, but now we know because we have the empirical data from the optimization trial. I'm getting excited. And so what this means is I am able to share my results to inform the way that somebody else might try to approach the same topic or the same component in a different intervention. We are contributing to science. So that is my favorite point. And then we are also, in this example, we only searched for components that produced a significant effect, but over time, we can include other implementation constraints that will, over time, increase intervention ease. So like I said, I'm going to be collecting all the data about cost, all the data about time, so that when we come to this problem again in that continual optimization principle, we have that information to inform the 2.0 version of our intervention. So we've identified our optimized intervention, and we decide that, yep, this is going to work. So we move into the evaluation phase. And I really, really enjoyed your point, Rachel, that it doesn't have to be a 2-arm RCT in the evaluation phase. The purpose of the optimization phase is very different than what we're, okay. So optimization phase is very different from evaluation. And so, right, in the optimization trial phase, where we've just come from, we do the factorial experiment because our goal is to look at the components individually and in combination. So the RCT can't do that. In the evaluation phase, the goal is to compare the optimized intervention to a suitable control. RCT does answer that question, but so does a factorial experiment. There are other ways to do that. And I think that what's been really exciting to see over the past several years is people really question, like, do you need the RCT at all? You've got the findings of your optimization trial. Why expend the resources for the RCT? That's a topic for a different talk, but really exciting to start to think about. Okay, so now we've made it through. That's really exciting. And now I'd like to just kind of walk through some alternatives and considerations about how most could be applied differently. So as Dr. Wells mentioned, when we talk about components of an intervention, we can talk about a couple different things in a couple different ways. So the example that I presented predominantly focuses on the content of the intervention, but we might design an entire intervention full of different components focused specifically on features that promote engagement, compliance, adherence, what have you. You might also have or seek to develop an intervention that is designed to improve fidelity. And so that means different things when you talk about the components. And I'll share that when, I want to apply most in the field of child maltreatment. And as I said, it's a very historic, well-developed field. We have lots of well-funded, well-supported, well-loved home visiting programs. And it can be really hard to come in and say, I want to do better. I want to change the status quo. So instead of focusing on the content of an intervention, because that could be a little bit of a tough pill to swallow, maybe I focus instead on engagement, because that is a problem that all home visiting programs have, not so much about the content. So as an alternative, maybe what I could do is to design an intervention that's like overlaid from the home visiting program, but this intervention is focused specifically on engagement. And so my goal, my outcome, is to see an increase in the number of sessions that are completed. To do this, I'm designing an intervention comprised of components designed to target access, information, support, social norms, motivation. So the point of intervention kind of changes here. And I think if you're in a space where maybe it's a difficult thing to suggest, try thinking about it when it comes from engagement or fidelity. Some thoughts and considerations here. Most can be used to develop new interventions, which you saw with my example. You heard about Cascade. Those are new conceptualizations of an intervention, but you can also use most to optimize an existing intervention. I think this is so exciting and has so much potential. The challenge, of course, is getting that intervention developer, maybe it's you, that would be great, to be on board with the idea that you might lose parts of that intervention, right? Through this optimization process, you might find that this component doesn't do anything. And so you would eliminate it. So you have to be sure that by taking on an existing intervention, you have kind of like the buy-in from the developer or the purveyor of that intervention. I don't have to spend too much time on this because Dr. Wells did mention that most in the factorial experiment can handle multi-level settings. So if you work in a clinic setting, a school setting, most and the factorial experiment can be applied in that space. There are different practicalities to kind of take into account, and I'd love to chat about that if that's something you need, but it can be done, has been done. And then I think that it's important to just kind of acknowledge that in some situations and spaces, most is just not the right choice. If you are not willing, or your colleagues or your field isn't willing to be able to let go of components of an intervention, then most is not the framework for you. And that's okay. I'll put that out there. And then, as Dr. Wells did, she also overviewed that most is extremely fundable. We have many examples of successful NIH grants, but not just NIH. I like to highlight Dr. Dion Odom's pilot work that was funded by a foundation. We also have examples of most funded by the Department of Defense. There's some interest in COERE recently, which I like to think more about. And then there is a growing enthusiasm for most in different countries. And so we've got folks from Australia pursuing it in their funding. and in the UK. So it is fundable. And I think the only thing that I would add to the conversation from previously is that most is fundable across career development stages. So Rachel really nicely presents how it can happen in a K99. There are other examples of a K23, so more of a mid-career change. You can come at this at any point in your career. And I think I just want to acknowledge that it can happen as a graduate student or as a very established senior scientist. So I hope that you, maybe, I don't hope that you felt this way at the beginning, but maybe you felt this way when we started my talk, but I am hopeful that by hearing how it can actually be applied and some of the considerations, that you are up for the challenge to break through that wall and take on most in your field of study. And I would love so very much to stay connected. This is my contact information, Twitter, I love it. And like Rachel, I'm a member of the OB-SIG at SBM, and we are really making an effort to put out a lot of resources surrounding most. So if you want more information, that's a good place to look for it. I'm gonna stop talking and stop sharing my screen.
All right. Well, thank you, Dr. Guastaferro, for that outstanding presentation. I always learn something new every time I listen to you talk. So I'm still taking notes on the side. And so we're ready for the questions. You know, we invite all of the attendees to post your questions in chat. And just know, like, if I ask you to unmute to ask your question, I would also appreciate if you would say your name and the institution or department that you're with. And I'm going to kick it off with a question that Dr. Dion Odom posed, which is, how do you go about scientifically justifying the selection of a component like peer mentoring in your example and its levels, which I think none versus some or group versus individual format or different things like that?
Well, I think it's a good question. And when I logged on this morning, we were sharing some of our favorite responses to questions. And so my answer to you, Nick, is, oh, it depends. But some thoughts here. Justifying a component, maybe like peer mentoring, I'm going to go through the literature and I'm going to make a case using theory that peer mentoring is going to affect my outcome. And I'll just say it doesn't have to be peer-reviewed papers. Maybe it's a dissertation. Maybe there is some type of scientific promise that shows peer mentoring is going to be important in this context. I think if it's something really new and radical that you're introducing to a new field that emphasizes or underscores the importance of the pilot work that you would do, being sure that that content or that presentation is acceptable to the people that you are going to be delivering it to, that it can feasibly be delivered by the providers you are training, all of those different elements. And I think there is some real art to making that case when it comes to a funder, especially if you're really like pushing the status quo. But it can and has been done.
Wonderful. Well, one of the things that I thought about when you were presenting, you mentioned a couple of things that I certainly did not touch on in my presentation, and one of those was the fractional factorial design. And I just wonder if you might give a blurb, like a sentence or two, about this design and why it might be a good fit for certain lines of inquiry.
Yep, great. And what is so funny is that I often this is just like a point of conversation for Linda and I often. So Linda, feel free to jump in. But the fractional factorial is a way to reduce the number of experimental conditions in a factorial experiment. And there are very specific considerations that happen with a fractional factorial and very specific situations in which that's really appropriate. So let's say that you've designed an intervention with 8 components if I'm a consultant on your grant, I'm going to suggest that that's a lot. Like, do you really know that you need 8 components? One option is you change what we call the granularity of those components to move things around and come to a number that is not 8. Or you might decide to pursue a fractional factorial. And that in choosing to use a fractional factorial design, you are saying that the higher order interactions you think are negligible, you're not so interested in. And so those interactions become aliased with other interactions, which means that you're kind of just letting them go. And that's fine. Scientifically, if you're on board with that, that's you can do this. But I think some considerations for when to choose a fractional factorial are if you really cannot pull off experimental, all of the different combinations, that's important. There are other things to say about this. I think if you are interested in a fractional factorial, there is a recommended reading list on the Intervention Optimization Initiative website that I would strongly recommend. And I think that there are practical reasons and choices for the fractional factorial, but I always want to like talk through those with people before recommending that experimental design just to begin with.
Yeah, thanks. I see that Dr. Sag has his hand up, so if you'll unmute and ask your question.
Thanks, Ken Sag, UAB. Thanks for another very clear talk. This is really a great start to this program. I really want to drill down, as you have started to, on the efficacy endpoints of both the optimization component and the future RCT. I think this idea about trying to figure out what works and what you can do most cost effectively in your multimodal intervention is an essential one that many of us have struggled with mightily over many years. And typically when we get to the full RCT, the goal is to power it adequately and usually only to use 2 arms because of the the large cost of doing this. And I guess I'm remain a little bit skeptical that, first of all, if you're going to do an adequately powered optimization design and demonstrate efficacy, it would seem like that would be answering your question fundamentally, as you sort of alluded to. And so why would you even need the RCT? Moreover, the general teachings are that factorial designs do require greater sample size. And when you start to look at all the interactions and all the comparisons, often it's it's at the expense of cost and power. So I'm interested in more discussion on that, because it seems like you're doing 2 fully powered studies within potentially a single experiment around trying to improve an outcome.
Yeah, okay, so I don't know if you knew this, Ken, but you asked about 46 different questions in that, but thank you. I think this is an exciting point. The first thing that I want to respond to is that this is one of the biggest misconceptions when it comes to the factorial experiment, that by having 16 experimental conditions, you need an unwieldy number of subjects. And the fact of the matter, and as Rachel Dr. Wells presented, the way in which you estimate the effects, it's actually a much more efficient use of subjects, and you often need fewer. So I'm unable to do 2 things at once, but I have a slide that shows that and could share it with you if you'd like. In Dr. Collins' book, she does a really nice explanation of this. So I think I just want to point that out. I also will acknowledge that there is a lot of, language is important, efficacy, effectiveness. I'm going to just say effectiveness for sake of argument here. But conceptually, I know that there's different. In the factorial experiment, you will be adequately powered to estimate the effects of each individual component, as well as the interactions, the combinations of those. And so in a sense, yes, you can answer all of the questions and determine effectiveness, efficacy within the factorial experiment. So why would you want to pursue an RCT? And trust me, I think we could have a lot of conversations about this. You might need to do that because that's what a program officer requires. That's what the field and like the history of science requires. But you don't have to potentially, and there's been some instances with most where a project officer requires you to do an RCT, but other situations in which the investigators have the answer at the end of the optimization trial, and that's the end of it, and they've decided that. So yeah, I think Ken, you've opened up quite a number of questions there, and I'm hedging a bit because I think that some of those things are going to come back up in later talks today. So stay tuned.
All right. Well, I think we have reached the end of this second talk. Dr. Guastaferro, thank you so much for a great talk. And I'm certainly interested in the future kind of discussion with the points that Dr. Sag brought up. We'll now have a 10-minute break until the next talk begins at the top of the hour at 10 o'clock. So thanks everybody for tuning in, and I'll see you all in 10 minutes.